Can start? Okay. Hi and a very good evening all. And we welcome you again to the webinar Diabetes India Oral Health Group, the last webinar of the year. And I, on behalf of the Dioh group, welcome the delegates who have joined today, the speakers for today's webinar. Unfortunately, our first speaker, Dr. Purnima Kumar, has got stuck up at one of the medical emergencies at her dental school. Thakkar sir. He's a well-known senior clinician hailing from New Delhi who perhaps needs no introduction, as he's familiar name in the diabetology community, both in India and on the international platform. And we thank you, sir, for accepting our invitation. And I also extend a warm welcome to the chairperson, Dr. Dhruvi Asnani, for accepting the invitation. We extend a warm welcome also to the Diabetes India Head Office representation, Dr. Vanchi Sabu sir, Secretary DI and the Chair IDF Southeast Asia, and Dr. Amit Gupta, Joint Secretary DI, for your kind words of encouragement that keeps the DIH on the progressive front for doing its better to best. And of course, the last but not the least, the DIH Young Turks, our special members, Dr. Anurag Satpathy and Dr. Gunjan Gupta, will be steering the evening with me as DIH host. The theme for this webinar is an extended arm of the oral health systemic nexus on an upcoming focused topic of clinical relevance, that's the crossroads of oral microbial dysbiosis, diabetes, obesity, and metabolic syndrome. Our esteemed speaker, which is for today's evening, is Dr. B.M. Makkar, will be dissecting this jigsaw shortly. So with these few words, let's go down to seek blessings from our Saraswati to initiate this scientific evening. Vandana, start kar de. Jignesh. Jignesh.
Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah. Shatru buddhi vinashaya dipajyotir namostute. Dipajyotir namostute. Dipajyotir parabrahma. Dipajyotir janardanah. Dipajyotir parabrahma. Dipajyotir janardanah. Dipo hartu me papam. Sandhya deepa namostute. Shubham
Thank you, Jignesh. So by the time the DI head office joins, I would now request the co-moderator for the evening, Dr. Gunjan Gupta, to start the scientific session. Over to you, Dr. Gunjan Gupta. She is the professor and head of the Department of Periodontology, ITS Dental College, Greater Noida. Over to you, Dr. Gunjan.
Thank you so much, Sangeeta ma'am. It's an honor and privilege to be here once again in this superb webinar organized by DIOH. And it gives me immense happiness and pleasure to introduce our chair of DIOH, Dr. Sangeeta ji. So today I'm going to introduce her as the chair, but not as a chairperson. So Dr. Sangeeta ji, she did her master's in periodontology from College of Dental Sciences, Davangere, Karnataka, and clinical externship program in implantology, University of Birmingham, United Kingdom. She has been credentiated by the International Congress of Oral Implantology as their fellow. She has been credentiated by Diabetes India as their fellow, awarded by Indian Medical Association Award of Excellence in Dentistry in the year 2024, Indian Medical Association Magnanimous Award of Excellence in Healthcare, ex-core committee member, National Oral Health Program, Ministry of Health and Family Welfare. She has served Indian Society of Periodontology in various capacities, ex-vice president, executive committee member, national convener, prenatal periodontal healthcare committee, assistant editor of Journal of ISP. She has been ex-editor-in-chief Journal of International Clinical Dental Research Organization. She is a reviewer for various national and international journals, was the organizing secretary of the first national symposium in India on periodontitis and diabetes in the year 2019. It was in the collaboration event of RSSDI and ISP and organizing chairman of the first Dioh Symposium 2024. She has numerous scientific publications, book chapters, and has been keynote and guest speaker at several dental and medical conferences, meetings on national and international forums. On this note, I would like to welcome you, ma'am.
Thank you, Dr. Gunjan. So we will just wait for maybe some time. Dr. Makkar is supposed to join, and once he joins, because we have only one speaker for the day, so I'm just waiting for Dr. Makkar has joined. Good evening, sir. Good evening, Dr. Makkar.
Sir is on mute.
Mute,
Sir.
yeah. Hi, good evening, sir. Good evening, Dr. Makkar.
आपकी आवाज नहीं आ रही है सर.
I think I have to tell him. Good evening, Dr. Makkar. Okay.
Makkar sir, can you try speaking once again so that we know that you can hear us? We are still unable to hear you. Sangeeta ma'am, can you hear his voice?
No, I can't. Let me just call him.
I think he's able to hear us because he's responding. We can see.
Just a second. Let me just tell him that we can't hear him.
Yeah.
Hello? We'll just give some time to Dr. Makkar to organize, and then we'll start his lecture. Good evening, Banshi sir.
Very, very good evening.
How are you? All well?
Very good.
So there's a small little glitch. The first speaker, Dr. Purnima, she is caught up in a medical emergency at her college, sir, at her institute. So she just confirmed that she's unable to join today. So we have just Dr. Makkar as a speaker for the evening, sir.
So this meeting is having with the background of AOCO, with diabetes, dental, and oral interest group. Lot of things are combined. Yes, I know that everything belongs to us, but still there is a lot of things are there.
Right.
See, Dr. Sangeeta Dheer, Anurag, both from very active group of oral interest group of Diabetes India. I can see Durvi. Otherwise, we are missing our type 1 meeting because of flights delay and cancellation. Since morning, actually, I'm the one who has gone airport. Actually, not gone, but constantly seeing what is the status of flights.
Right.
Not reach yet. I was seeing Dr. Makkar, he left out.
No. I think he's unable to connect on the audio front. Someone is helping us with back end. So kind of, I think he's just
Good.
Joining.
Banshi sir, we just have the news from somewhere. It's flashing that the DGCA has pulled back all those things, and the
Yes.
flights will be back and operational.
It will be back in operation, but still, there will be a lot of backlog now.
Mm.
Tomorrow
It's
morning,
a
you want to go?
That's supposedly why I'm asking you that should we try seeing those things tomorrow or should we take the train?
I don't.
Yeah, I don't.
Hi, Dr. Makkar. Are you connected? No.
Dr. Makkar is, I think, not in India, bro. He was in Korea. Now he's in somewhere in Europe, in different time zone.
Yeah. What is
Makkar sahab,
happening?
Now I think he's not able to hear us or something.
no, we can't hear him. He's speaking.
Mhm. Yeah, he's
He-
speaking.
He's in Europe.
सर आपका नहीं नहीं बिल्कुल नहीं सुन रहा था, अभी तो आपको कॉल कर रहे थे. ठीक है ठीक है ठीक है सर, ठीक है ओके.
नहीं, लेकिन अभी भी वो ब्लू आवाज नहीं आ रही है मक्कर साहब.
नहीं नहीं वो कहते हैं उनका ब्लूटूथ का कुछ आपकी डिसोरिएंटेशन लग रही है, तो लेट मी कनेक्ट अगेन. सो ही इज थिंकिंग दैट वी कैन हियर, मैं कहा वी कैन नॉट हियर अ वर्ड. कहते दोबारा कनेक्ट करता हूँ.
But he's in Europe somewhere.
Yeah, he did say. I think, I think Paris की कहीं तो बता रहे थे. He's there somewhere.
There is some ESO meeting is there.
Right, sir. So what are the agendas, Dr. Bansi sir, for 2026? What plans?
A lot of plans,
Hmm?
but now everything is moving around obesity.
Right.
Luckily not.
True.
But obesity indirectly, definitely, oral route is the most important, and that's what we are closing.
Right.
So even patient comes with a complaint of any dental issue, we ask him to take the
Diabetes.
GLP-1 and GIP injection. And we say because it will give rest to your denture
Right.
and you will be cured.
Ah.
So the only treatment for everything. You have cardiac, you have kidney, you have liver, even you have oral issue, you have obesity, you have diabetes, any issue, the treatment is one only.
Right.
Dr. Makkar Saab,
नहीं हो रहा connect.
it is showing constantly connecting to audio, connecting to audio.
Hmm.
मक्कर सर का बोले कि वो ब्लूटूथ निकाल के एक बार ट्राई करे.
बोला
he
था
can
मैंने
try the
दोबारा.
phone speaker directly without
Hmm.
the Bluetooth device. That might help.
Let me just tell him again.
Hmm.
Sujata just now returned a message that, all flights, even at Bombay, also airport is cancelled.
I read her message in the group.
Very sad.
Yeah, it's very sad. And for her, it's even more difficult, being in the
Very
middle of
difficult. Now she
nowhere.
can't go back
She's
and she
not,
has to stay in Mumbai
yeah,
airport. So
yeah.
not able to attend, and I don't know exactly on the same day.
Yeah.
We're waiting for. So till that, Sangeeta ji, can we give second speaker?
So second speaker is Dr. Makkad only, and he's the first and second both. As I said, Dr. Purnima is unable to join. As I told you, she's got stuff in some emergency at the college at America. So she just called 1 hour prior, just 1 hour prior, extending the apologies
So
that
can you
she's
just
unable
show
to
the
join.
agenda of the meeting
Yeah,
to
sir.
everyone and we start?
Yeah, so we just requested Dr. Makkar Kate, we'll just start right away. So I'm just waiting for him.
No problem. But till that, what is the
Yeah. Jignesh.
agenda of meeting and we just
Jignesh.
show.
Meeting agenda show kar de.
Yeah. So it's a gum disease, diabetes, metabolic syndrome, understanding the risk.
Right, sir.
The speaker are here. It is not written.
So Jignesh, program flow. So we just had two speakers, Dr. Banchi. One was Dr. Purnima and Dr. Makkar. So she had to highlight the research point of view about the oral and gut axis. And Dr. Makkar was going to be, dissecting the connection part, pathomechanistic part. That's the way how we had planned.
Okay.
So unfortunately, she is unable to join. So it's only Dr. Makkar who is going to be taking the baton forward.
And
So
how
maybe-
many delegates today we have?
So we have registered, I think registration, he said some 60 odd had logged in. So this is like when we started at 7:15, some login would be there right now.
So this is
Yeah,
the
That's the agenda.
this is the agenda.
Yeah.
Oral and Gut Microbial Axis, a research spotlight by Professor Dr. Purnima Kumar, and Metabolic Syndrome, Diabetes and Oral Health, Understanding the Connect by Makkar sir.
So 8 to 8:30, Dr. Makkar will talk. Is it
Yeah,
fine?
so it was planned like that. So, but he said I will join. So it's taking a little time. So by the time he joins, it's going to be a quarter to
Till
2.
that, Sangeeta ji, you can start your welcome, inauguration, welcome.
We did that.
Yeah, we have already done that also.
We have done that already.
So how often, let us have an informal discussion. So obesity struck population which is coming to the diabetologist, Dr. Dhruvi, Dr. Bansi sir. I'm sure it will be in loads, right?
So Dr. Makkar join.
I hope
Can you
yes,
hear me
sir.
now?
Yes,
Yes,
now
yes.
we
We
can
can hear
hear.
you, sir.
Yes.
Yes, finally.
I don't know what went wrong because just before this I was in
So
another Zoom
Dominica
meeting. It was
joined,
working.
I think.
No, it's okay. Not a problem, sir. It's okay. Perfectly fine, sir. So, Jignesh, we'll be starting it. Can we have Dr. Dhruvi Asnani's introduction slide, please? Dr. Jignesh? We have the first session starting as the only session apparently. So I take this privilege to welcome the chairperson for the session, Dr. Dhruvi Asnani. She's ex-consultant diabetologist, Rudraksh Institute of Medical Sciences. She's HOD Clinical Research, RIMS Ahmedabad. She's the governing council member, RSDI Gujarat chapter. She's the winner of Torrent Young Scholar Award for Diabetes, Rising Star Awards at Diecare Con, JPAF, Dear Diabetes Academy, International Congress of Obesity, Early Career Physician Award from American College of Physicians. She's a faculty for National Diabetes Education Program. She's a speaker at numerous international and national conferences and author for international and national publications and consensus guidelines. She is an editorial board member of Journal of Clinical Diabetology. She's a reviewer for Pediatric Diabetology, Journal of Diabetology, Journal of Pediatric Endocrinology and Metabolism, International Journal of Diabetes and Technology, American Diabetes Association abstracts, and also is an investigator for clinical trials. We welcome you, Dr. Dhruvi, and we request you to kindly introduce the speaker, Dr. Banchi Sabu, sir.
I'm not the speaker, Dr.
Sorry. Dr. Bakkar. Sorry. I'm sorry. I'm sorry. Jignesh.
You made my job easy actually.
Doctor,
And we
over to
can
you,
see
doctor.
Dominica. Hello, how are you?
Hello Dominica, how are you?
Yeah, Yeah, Dr. Dhruvi,
Yes.
you can
Yeah.
start it. Yeah.
Yeah, thank you. Thank you so much, ma'am. Thank you, Dr. Sangeeta Dheer, ma'am, and the entire interest group of Diabetes India who's working so hard for the oral health group. I have the privilege today in introducing one of the leading and the most respected figures in diabetes care, Dr. B.M. Makkad sir, in the presence of my mentor, Dr. Banshi Sabu sir. Makkad sir is the past president RSSDI, honorary secretary of AERO. He is the honorary secretary of RSSDI from 2017 to 19, ex-chairman RSSDI Delhi chapter, member of the executive board Diabetes India, member of the ACE International Committee, member of the ACE Professional Business Committee, the course director for ACCD in collaboration
Dhruvi,
with
I
the
think we can
Cleveland.
skip this. We can
But
skip.
with so many accolades, awards, orations, and work in his name, we have the privilege of listening to Dr. Makkad sir talk about the connection between metabolic syndrome and oral health. With that, thank you, Makkad sir, for joining us today.
Thank you, Dhruvi, and thank you, Dr. Sangeeta, for this great opportunity. I must thank, in fact, Dr. Bansi, Dr. Sangeeta, everyone in the organization for this great opportunity. I must also confess that this is, I think, first time I am going to speak on oral health in diabetes or metabolic syndrome. And Bansi has always been very, instrumental in giving me topics which I don't understand or which I don't read normally. So he makes me read. That is also important. So I will try my level best to give you a concept, and hopefully I will be able to do justice to the topic. I am sharing my slides. Can you see my slide now?
Yes, sir.
Yes, sir.
So as you see, my topic is metabolic syndrome, diabetes, and oral health, understanding the connect. I don't have any financial disclosures for this presentation. Now, we know diabetes is a huge problem globally, and this is the recent most data that we got from IDF when IDF Atlas was published last year. It showed that we have close to 600 million people living with diabetes globally. 1 in 9 adults has diabetes, 1 in 8 adults has fasting glucose impaired, 1 in 11 has impaired glucose fasting. Sorry, 1 in 8 has impaired glucose tolerance, and 1 in 11 has impaired fasting glucose. And 1 in 4 above the age of 65 is having diabetes. So, such is the magnitude. Now, it is not just this is the magnitude, we are also looking at a steep rise in prevalence of diabetes globally, especially in Southeast Asia, where we are living. Now, if you look at the Indian data, the numbers are very, very alarming. And if we look at the ICMR data, INDIAB ICMR study, which was published 2023, it showed that we have almost 11% of the adult population having diabetes, and the numbers which are estimated is about 101 million people having diabetes. Now, it is not just diabetes that is there. The numbers of other metabolic disorders or non-communicable diseases is alarming. And if you look at the prevalence of obesity, we are estimating a number of 351 million, or about 40% of adult population in India having central obesity, and almost 30% having the generalized obesity. If we look at the urban population, these figures go to 40% and 50%. In addition, we have almost 25% people living with hypertension. We have a significant load of dyslipidemia marked by increased TG and low HDL, which is classically the component of metabolic syndrome. Now, what is metabolic syndrome? Metabolic syndrome was a term given way back in early 2000 by NCP ATP 3 guidelines, and basically it means that there is a cluster of metabolic abnormalities which occur together in an individual more often than might be expected only by chance. And they are associated with increased cardiovascular disease risk, and the underlying factor is insulin resistance. Now, when NCP ADP3 guidelines came, it suggested that we should make a diagnosis of metabolic syndrome based on presence of 3 out of 5 components. The first one is central obesity, second is increased TG, third is low HDL level, in presence of blood pressure or on treatment for hypertension, and presence of dysglycemia or on treatment for diabetes. 2005, IDF suggested that we should take central obesity as the mandatory component of metabolic syndrome, and we should look for another 2 out of the 4 factors. That means increased TG levels above 150, HDL less than 40, raised blood pressure or on treatment for blood pressure, raised glucose or on treatment for diabetes. So basically, the diagnosis is based on presence of 3 components out of 5. Now, let me again touch on basics about the periodontium, or the main component of oral health. So what is periodontium? It is a specialized group of tissue that surrounds this and supports teeth, consists of 4 main components: the gingiva or gum, the periodontal ligament, which keeps it intact in the bone, cementum, which covers the tooth root, and the alveolar bone around it. Now, any of these structures, when it gets affected or damaged, it, challenges the normal oral health. Now, functions of periodontium is to anchor the teeth firmly, to provide cushioning during the chewing process, and maintain health and stability of teeth within the jaw. Dental plaque is a community of microorganisms that is found on the tooth surface as a biofilm, which is embedded in a matrix of polymers which come both from host and the bacterial origin. Now, plaque is natural and contributes, like the resident microflora at all other sites, to normal development of physiology and defenses of the host. What is the clinical relevance? The biofilms are susceptible to antimicrobial agents, and the microbial communities can display the enhanced pathogenicity when there is pathogenic synergism, and this can become resistant to the antibiotics also. Now let us see what is the magnitude of problem. Globally, almost anywhere around 30 to 50% of people are affected by periodontal disease, and the rate of gum diseases goes on increasing with age. It is estimated that 60% of adults over 65 years of age have some or other form of gum disease, and 10% of the world population has severe periodontitis. Now, in India, it is estimated that 85% of the population has some form of gum disease, which can be swollen gums, receding gums, bleeding gums, gingivitis, periodontitis, whatever. But almost 8 out of 10 people get affected with oral health challenges. Now, let me take you through briefly the link between obesity, insulin resistance, and meds. What is obesity? Obesity is basically defined as abnormal or excessive fat accumulation that impairs health. Now, this definition has been too simplistic, and now, with recognition of obesity as a very important disease, the definition has been expanded, and the current definition from Obesity Medicine Association says that obesity is a serious, chronic, progressive, relapsing, and treatable multifactorial neurobehavioral disease wherein increase in adiposity promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biochemical, and psychosocial health sequences. So, this is a disease where there are multiple factors contributing to development of disease, has multiple implications in terms of health, whether it is the biomechanical implications, whether it is metabolic implications, psychosocial implications, and even the mental health challenges. Now, what causes the dysmetabolic state in obesity? Now, when we say it is a disease, it is not just sheer excess of fat, it is harmful fat that is there. Now, how this fat, becomes harmful? To understand this, we have to understand the process of fat storage. When there is excess energy, it is largely stored as triglycerides in adipose tissue, in the white adipose tissue. And this becomes a storage when there is need for calories, such as starvation or during exercise. Now, white adipose tissue can store more triglycerides by either increasing the number of cells or by increasing the size of cells or the size of adipocytes. Now, when there is increase in fat accumulation by increasing the size of adipocytes, these adipocytes become, stressed and they become inflamed. Their function becomes dysregulated, and they start working like an the endocrine organ. They become inflamed. They start throwing out the free fatty acids. They also start secreting number of vascular and inflammatory adipocytokines. And these molecules play very important role in causing dyslipidemia, decreasing the insulin action, increasing the insulin resistance, increasing inflammation, leading to endothelial dysfunction, dis, disimmune, immune dysfunction, and also secretion of prostaglandins. So, in nutshell, what happens is once there is excess calories, there can be two things. One is the increase in number of cells, which is termed as metabolically healthy obesity, and other is the classical obesity, where there is increase in cell size due to increase in storage of triglycerides. And these cells become inflamed, start releasing free fatty acids and adipocytokines, leading to development of insulin resistance. On the other side, there may be only increase in number of cells without increase in size. This does not lead to inflammation, and this stays a metabolically healthy state. Now, I'm not going into detail of this because now we have enough data to show that metabolically healthy obesity is only a transient state between a normal body weight to classical obesity with its cardiometabolic or other biomechanical dysfunction. Now, there are three different mechanisms which have been proposed to link obesity to insulin resistance and predisposition to get diabetes. First is the increased production of adipocytokines, which include TNF alpha, IL-6, resistin, RPB4, and also reduced level of adiponectin. Second is the ectopic, deposition of fat, especially in liver, pancreas, and muscle, leading to dysmetabolic state. And last but not least is the mitochondrial dysfunction. Now, this has been shown in various studies that decrease in mitochondrial mass or function, and mitochondrial dysfunction could be possibly the main underlying defect linking obesity to diabetes, both by decreasing insulin sensitivity and by compromising the beta cell function. Now, what happens is once there is increased free fatty acids, there is reduced adiponectin, there is increased leptin levels and in leptin resistance, and there is high demand for insulin because there is excess caloric intake which is getting pumped into adipose tissue, leading to adipose tissue hypertrophy or hyperplasia, leading to adipocyte inflammation, release in adipocytokines, and immune dysfunction, ultimately leading to insulin resistance. On the other side, in pancreatic beta cell, there is again increase in endoplasmic stress, increased production of free radicals, and islet cell inflammation and dysfunction, leading to insulin insufficiency. Now, this insufficiency leads to decreased insulin secretion. On the other side, if you have the insulin resistance, it leads to increased demand. So there is a gap between demand and supply of insulin, and this leads to the hyperglycemia of diabetes. Sorry. Now, there is a possibility that both obesity and diabetes share a common underlying defect, and the defects which favor weight gain also lead to impairment of beta cell function and development of insulin resistance. Now, how does this work? There is a very good, hypothesis which has been developed, and this also defines obesity as something called ABCD, or adiposity-based chronic disease. Now, what happens is, in individuals who have genetic predisposition and are exposed to environmental factors or behavior changes, and also have some epigenetic factors, there is first increase in the amount of overweight or increased accumulation of fat in body. Now, once there is excess accumulation of fat above a threshold level, this leads to either abnormal distribution or abnormal function, or both. Once there is excessive fat and abnormal function, this leads to development of so-called obesity once you cross the BMI thresholds. And there is abnormalities in function leading to the biochemical abnormalities. And this is the state of initial cardiometabolic dysfunction, or biomechanical factors become active, and you may get only impact on like joints or obstructive sleep apnea and other kind of complications. Once there is abnormal function, this leads to development of insulin resistance, which in turn can progress to prediabetes, diabetes, and diabetes-related complications on one side. On the other side, person may not get dysglycemia, but go on to develop metabolic syndrome caused by, characterized by increase in blood pressure and dyslipidemia and obesity. And this is the stage called cardiometabolic based chronic disease. The stage at which diabetes becomes manifest is called dysglycemia based chronic disease. Now, once the person gets metabolic syndrome, it can go on to develop the subclinical coronary disease, LV dysfunction, LA abnormality, finally progressing to symptomatic coronary artery disease, heart failure, and atrial fibrillation. So this is, in brief, the whole process, how obesity is leading to diabetes and metabolic syndrome, and how obesity, insulin resistance, diabetes, and metabolic syndrome are connected. So we have it's a complete set of conditions which are interconnected, and we don't have much to differentiate between diabetes and obesity or metabolic syndrome, because they all have underlying cause as insulin resistance. Now, once person gets diabetes, this leads to production, increased inflammation, and increased production of free radicals, which predispose to development of atherosclerosis and leading to cardiometabolic complications on one side. And on the other side, you have the adipocytokines and pro-inflammatory molecules coming from the adipocytes due to obesity, and they are also leading to increased risk of cardiometabolic diseases, the cardiovascular risk, and risk of heart failure. So both metabolic syndrome and diabetes contribute to development of this. And if you go to the details of how adiposity is contributing to this, now you can see this is a very complex, picture, but what you see here is that there is increased adiposity, which leads to development of insulin resistance on one side, contributing to type 2 diabetes. There is increased lipid production, lipotoxicity leading to fatty liver disease or MASLD, and also contributing to coronary artery disease due to dyslipidemia and stroke and heart failure and kidney disease. This also leads to increase in the production of adipocytokines and activation of RAS activity, which lead to renal complications or the mechanical complications like osteoarthritis and obstructive sleep apnea. And all these are interconnected. Now, let us see how is the metabolic syndrome and pre-diabetic conditions are connected with oral health. And this was a study which looked at the associations of pre-diabetic conditions with dental and oral pathologies and potential role as metabolic health marker. This study analyzed data from 45 overweight obese subjects with hyperglycemia and obesity and 30 normal healthy volunteers, and assessed the components of metabolic syndrome and oral health status looking at the were determination of various indices of caries, periodontal bleeding, and oral hygiene indices. And results showed that there was a significantly higher incidence of periodontal diseases in the study group. That means people who had metabolic syndrome or diabetes versus controls. And this was strongly associated with increased waist circumference, visceral fat, increased levels of hypertension, dyslipidemia, and gout. So studies showed that periodontal inflammatory disease, which was diagnosed in 42 of the 45 patients, while the control group had only 3 patients affected, it showed that dental and oral pathologies are overexpressed in obesity and prediabetes and affect the quality of life and can be used for patient stratification and considered for personalized treatment. Now, ADA guideline has also actually given a focus on dental care and states that people with diabetes should be referred for dental examination at least once a year, and coordinated efforts between the medical and dental teams to appropriately adjust the glucose lowering medication and treatment plans prior to and in the post dental procedure period are needed. Now, I am going to show you some data on how these things are connected and how they impact the presence of each other. So this was a systematic review looking at oral hygiene and metabolic syndrome, and this evaluated the association between oral hygiene status and metabolic syndrome. This was based on the research on PubMed and Web Science from inception till 17th March 2021. And random effect model was applied to pool the effects of oral health status care of metabolic syndrome. 13 studies met the inclusion criteria and had sufficient methodological quality. The lower risk of metabolic syndrome was seen in people who had good oral hygiene with odds ratio of only 0.3, frequent toothbrushing with the odds ratio of 0.68, and frequent interdental cleaning with the odds ratio of 0.89. So, good oral hygiene was associated with low risk of metabolic syndrome, and this is the results from this study clearly showing, a favorable impact of good oral hygiene in reducing the risk of metabolic syndrome. So results suggested that there may be inverse association with oral hygiene status, toothbrush frequency, and interdental cleaning with metabolic syndrome. Now, this was, again, another study which looked at the periodontitis and diabetes and showed a bidirectional relationship. There is recent meta-epidemiological data based on 15 cohort studies with average follow-up of 9 to 11 years, showed a 56% higher risk of diabetes incidence in individuals with periodontitis and 55% higher risk of periodontitis in those with diabetes. So those who have diabetes have higher risk of periodontitis, and those who have periodontitis have a significantly higher risk of getting diabetes. So this is another meta-analysis which looked at the systemic effects of periodontal treatment on diabetes with specific focus on type 2 diabetes patients and investigated the overall systemic effects of periodontal treatment at 6 months follow-up. The study showed that periodontal therapy was reported to reduce the fasting glucose levels, the markers of inflammation, and interleukin 6 also. So again, beneficial effects of controlling hyperglycemia on the oral health. Another recent meta-analysis of 12 randomized controls at least 6 months follow-up showing that subgingival instrumentation resulted in 0.29% lower A1C compared to non-treatment. The converse is also true. Good diabetes control achieved mainly through dietary counseling and oral health was shown to be associated with improvement in the periodontal clinical parameters over a follow-up period of ranging from 4 weeks to 6 months after intervention, such as bleeding on probing or probing depth or clinical attachment levels, all these improved, in by improving the lifestyle changes in people with diabetes. Another recent meta-analysis showed the systematic effects of periodontal treatment on diabetes with specific focus on type 2 diabetes. I think this was the study which I showed earlier. Another interesting study is the impact of metformin on oral health. And this has been shown that metformin usage has been, shown to reduce the periodontal bone loss in rat model and ligature-induced periodontitis. 20 randomized control trials performed to assess whether locally delivered metformin gels can change the clinical periodontal parameters showed that results a significant beneficial adjunctive effect of locally delivered metformin was there in terms of improvement in the dental health scores. Now, if you look at the epidemiological study, there is significant association between obesity, periodontal disease in children, adolescents, and adults. And obesity is associated with increased risk of onset of periodontitis, increased severity of disease, and those with periodontitis and poorer outcomes following the periodontal treatment. So you have similar, data coming from obesity. And studies in people with obesity have shown that they have 3 times higher risk of getting periodontitis and poor response to non-surgical treatment of periodontitis. So you have bidirectional relationship between obesity and periodontitis and between diabetes and periodontitis. This is another, study which reported a linear relationship between periodontitis progression and BMI over a period of 5 years, with a significant estimate after even adjusting for age, smoking, and history of diabetes. The same results were confirmed by a 40-year retrospective investigation conducted in US veterans and by a Mendelian randomization analysis performed on the UK biobank data set with summary level genotype data and showed by the Jiva studies also. So in nutshell, you have, chronic periodontitis, which leads to immune dysfunction and cytokine imbalance, leading to increased inflammatory markers. And this in turn leads to increase in systemic inflammation and insulin resistance, which in turn leads to hyperglycemia and diabetes and increased A1C. Once there is hyperglycemia, this promotes in turn the chronic periodontitis. So there is a vicious cycle going on. And it is not just bidirectional relationship, it is actually three-prong or tridirectional, I would say, relationship, whereby diabetes is worsened by obesity. Obesity predisposes to diabetes as well as periodontitis. Diabetes leads to a pro-inflammatory state. Obesity also leads to pro-inflammatory state, and both lead to increased risk of periodontitis. And once there is periodontitis and diabetes and obesity, there is all contributing to increased risk of cardiovascular disease or metabolic dysfunction. And this slide also shows you number of factors which predispose to all these diseases. And once there is poor oral health, there is low-grade systemic inflammation, which is leading to damage not only in terms of causation or increasing the risk of diabetes and metabolic syndrome, there is increased risk of atherosclerosis, NAFLD, diabetes, kidney disease, stroke, and everything, as I showed you in my earlier slide also. So what should we do in such a situation? Once you have a patient coming to attend the general dental practice and you find there is, a poor oral health, you should provide information between the link of periodontitis and diabetes and metabolic syndrome. there is no issue with the oral health. Routine dental care is given. Now, somebody is attending the general medicine OPD and a diabetes is diagnosed or metabolic syndrome is diagnosed, look for the oral health issues and provide information about the uh, the importance of oral health in people with diabetes, obesity, and metabolic syndrome. And also, for the slightest issue, you should refer the patient to a dental surgeon. This is something called Make Every Contact Count, or MECC pyramid, based on the MECC consensus. And everybody in direct contact with general public, try to provide the information, the baseline information about oral health and metabolic syndrome. And staff or people working in the healthcare, when they come in contact with patients with short period of time, should try to impart the brief information both about metabolic syndrome and oral health. Once the staff is coming, or the healthcare workers are coming in contact with people for more than 30 minutes, they should discuss even more information. And once the person has reached the specialist or practitioner, I think we need to give all the information to people to understand the link between two conditions. So in dental setting, information on oral systemic link and signposting the patient to medical practitioners is important. Medical setting, the signposting of patient to dental practice is also important. Lifestyle modifications are part of both, whether it is the metabolic syndrome or orodental health. And oral health promotion as a part of medical disease management should also be taken up as an important priority. To sum up my presentation, there is a multimorbid relationship between periodontitis and metabolic diseases like diabetes, obesity, and metabolic syndrome, and it is now well established. The interplay among periodontitis, diabetes, obesity is sustained by shared biological mechanisms, which include systemic inflammation, insulin resistance, and metabolic dysfunction. And one thing that I have actually, not added in this presentation is the role of microbiome. There is dysfunctional microbiome which plays important role in leading to poor oral health and periodontitis. And there is a dysfunctional microbiome which is also component in the causation of diabetes and metabolic syndrome. So that is one aspect, but we have very limited data how it works and what to do about this. And the available evidence suggests the need for paradigm shift from a single disease to multiple disease approach. With that, I conclude my presentation. I would also like all of you to come for the AOCO 2025 Asia Oceania Conference on Obesity that we are hosting in New Delhi between 19 to 21st of December. Thank you very much for your patient hearing. I'll be happy to take the questions that I can answer, and otherwise I will pass them on to my dental health partners who are there on the screen.
Thank you, Makkar sir. This was a very illustrative, I would say, presentation, a trialogue, a dialogue, wherever we start from. Obesity is the central line axis, is what we understand. And you had covered it beautifully. And thank you so much for your lecture, sir. Dr. Anurag will be taking over next. Jignesh, can we have his introduction slide, please? So I would like to invite the discussion round by Dr. Anurag Satpathy. He's a professor and head, Department of Perio, Institute of Dental Sciences, SOS University, Bhubaneswar. He is an alumni of BVP Pune and completed his post-graduation from SDM Dharwad and earned his PhD in Dental Sciences from SOS University, Bhubaneswar. He's a prolific researcher with over 100 index publications and 50 citations and has been consecutively featured in 80 scientific index. He has multiple patents to his name. He's the editor of the Journal of Odisha State Dental Association and on the editorial boards of various journals. He has his leadership roles, including EC membership of the ISP and scientific chair of a couple of conferences that he had organized and hosted. He's also a member, secretary of the Institutional Ethical Board of the college, and he's also a active member of the Diabetes India Oral Health Group. Over to you, Dr. Anurag, for taking the deliberations forward.
Thank you so much, ma'am, for that lovely introduction. I would like to thank Dr. Makkad for this wonderful presentation, sir. Now, we have been concentrating on the bidirectional relationship between periodontitis and diabetes mellitus, which you have also covered in your presentation. However, the light that you have thrown today is about the tridirectional relationship. The fact that obesity is around 40% in prevalence, and that too the central obesity, growing more in the urban population is alarming. Something that you have focused and it goes very unnoticed. People actually probably do not want to accept the fact that they are obese. And the central obesity, where the visceral fat comes into play, is more important. A study was conducted in AIMS also, where the central obesity was shown to be more detrimental rather than the entire body. Thank you for covering the metabolic syndrome, which is a combination of the three major factors that you highlighted, and primarily considering the WHR first. The WHR probably is not very commonly recorded in our settings, which I think we should take into consideration. What we go for is maybe the weight and the height and go for the BMI. So WHR should be taught also how to correctly be taken. Thank you for that insight, sir. The periodontitis, which you have rightly pointed out, and we have been focusing as a Diabetes India Oral Health Group as our focus area. However, we have probably missed this aspect of obesity all through. The metabolic syndrome is something which goes hand in hand with the diabetes, is a true reality, and thankfully you have pointed out correctly. Probably in our further deliberations, we will make it a point to highlight the metabolic syndrome and the obesity, and in particular the central obesity, as the important point in our discussions, because we probably are missing that. You highlighted how the mitochondrial dysfunction, the diabetes mellitus, the obesity, and the metabolic syndrome all come and converge at insulin resistance, leading further to the systemic complications, most likely the MI, strokes, and the congestive cardiac failures. The association, which is both from the periodontitis point of view and the diabetes, and also the recent research which shows that when we have good oral health, then there is also a decrease in the diabetes status, or the glycemic index is well documented. And you have fantastically shown the algorithm how from the dental office the medical counterpart should be sending the signposts, and from the medical office to the dental office how they should be communicating. The MECC that you have highlighted, sir, is something new that we also need to adapt to our faculty, and it is a very wonderful introduction. Probably we need to work on it and how we can adapt this concept in particular focus to the diabetes and oral health, and we will do that, sir. The dysbiases that you mentioned towards the end, probably we are unfortunate that Dr. Purnima could not join today. That was the topic that she would have taken, because not only the oral dysbiasis but also the gut dysbiasis is presently the focus, and the oral gut brain axis now plays a role.
Actually,
So,
that is why I had not, added that to my presentation,
Right.
because it would have made it very long, and that
yes, sir.
itself is a full subject in itself now.
Right, sir. Having summarized this, one question from my side to you, sir. We have obesity of different shapes also, like we have the apple and the pear types. So does that shape play a role in the
So,
systemic inflammation?
Basically, the initial understanding of obesity, when we first time we started developing the understanding of obesity actually as a disease, we looked at two different components, that obesity in men is more harmful than in women.
Okay.
And if you look at the shape, the gynecoid obesity is that you have more accumulation of fat around the pelvic region, and in the central obesity you have more accumulation of fat in the stomach region. Now, we did not have much differentiation that time in visceral fat and non-visceral fat or subcutaneous fat, but we came to realize that people who had central obesity had higher risk.
Right.
And the central obesity was considered as a separate parameter. If you look at the guidelines that were there in 2000 or before that, WHO mentioned the cutoffs at, the first cutoffs were mentioned at 25 as overweight, 30 as, obesity. So 30 to 35 was stage 1 obesity, 30 to 35 to 40 was stage 2, and then was stage 3. Now, if you have stage 1 obesity and waist circumference more than 90 or 100 centimeters, that were the initial cutoffs, then it would add to one more stage. That is how the classification was. So you have stage 1 obesity and increased waist circumference, it becomes stage 2. Stage 2 obesity and increased circumference, you become stage 3 because of the increased risk of central obesity. But then we have, more and more studies, and we know that it is the visceral fat, it is not subcutaneous fat, which is causing problem. So apple shape obesity is basically when you have central accumulation of fat, and gynecoid obesity is when you have pelvifemoral accumulation of fat. Now, another thing you have to keep in mind is that if you have BMI more than 35, all obesity has central obesity. Even if the
Yes.
shape is gynecoid obesity, you have to take into account the central obesity because it is bound to be present. So central fat, which is the visceral fat, is thought to be more active, or inflammation wise, or the it has more of sympathetic innervation, more vascular, so more release of adipocytokines and free fatty acids from visceral fat. And now it is not just the omental fat we are looking at. Initially, we thought it is only the visceral fat. That means viscera is omentum. Now this fat is there everywhere. The visceral fat means ectopic fat in liver, ectopic fat in pancreas, ectopic fat in around the kidney, ectopic fat around the heart. So EPAT is new term for epicardial fat. So all these fat, whether they are around the tissue or within the tissue, are having a harmful effect. And this ectopic fat now is supposed to play a bigger role. When we say ectopic fat leads to development of diabetes, you know how much is the total excess fat that is there in pancreas? It is only about 1.5 grams,
Oh.
which makes it, from normal to diabetes state.
Right.
And when we says remission of diabetes, there is only fat that you drive out of pancreas is only about 1 to 1.5 grams. So
So,
fat
so sir,
has its own impact. And the major problem now that we are dealing with is fat. Initially, we thought obesity was a sign of affluence. Even now in India, large number of people consider obesity as a sign of affluence because we came out of poverty 40 years back. But now we know that every sign of every cycle of famine is followed by obesity.
yes,
Worldwide, this has been seen. This happened during Danish famine. After that, there was, surge in diabetes and obesity. This has happened in India, and this is going to happen in China. Is also seeing surge because China also had famine 40 years back. So it takes about 30 to 40 years to get the surge of obesity following a famine.
Right. Right.
sir, is there any special tests that we can recommend or ask to measure or know the fat levels?
We don't do it Because to measure now we have started doing it because obesity by definition is excess fat, and we were using only surrogate measures. We were measuring weight, not fat. So
Yes.
BMI can have some issues. But if you look at the correlation between the fat mass and the body mass index, there is very strong correlation. It's almost linear. But yes, there are some outliers. So body composition can be analyzed using the bioimpedance
Yeah.
scales, which are
Right.
easily available. But you
Yes.
should use the accurate one. And India, second thing is they are not standardized to Indian, parameters.
Setups.
But now
Right.
we have data to show that women should have a fat percentage of less than 32 or 35%, and men should have less than 22%. The ideal way of measuring is either the DEXA scan or MRI to measure the exact amount of
Right.
fat. But important thing is if you have a waist circumference of about 90 centimeters for men or 80 for women, consider that there is going to be significant visceral fat. And another important parameter now is to measure waist to height ratio. So waist circumference should be less than half of the height.
Right.
If it is more than that, it is considered central obesity.
And so, how about apart from anthropometric measurements, what do you share your thought on the any biomarkers of interest you think could be clinically relevant?
So commonly used biomarker is HSCRP, high sensitivity
That should be
CRP. If it is
inflammation, yeah.
increased, then you
Mm.
you consider there is systemic inflammation.
Right. But that would be a generic systemic inflammation.
Yeah.
Is there
Yeah.
anything specific to pick up the adiposity, would you think? Adipokine or something
But
like that?
see, we don't need to measure all this.
Mhm.
Once you have clinical markers like insulin resistance, you have acanthosis.
Right.
You have skin tags which can come up,
Mhm.
or you have dyslipidemia, which is itself a marker of
Mm.
insulin resistance. You have high triglyceride, low HDL, you have high blood pressure, you have dysglycemia, you have pre-diabetes. All these are important markers. You have, and MASL now, the metabolic steatohepatitis
Yes.
dysfunction
Yeah.
associated
Yeah.
steatohepatitis, or the
Right.
fatty liver,
Mhm.
or you have, mm, what else? These are broadly the clinical markers that you can
Markers, right.
easily pick up. You can pick
Right.
up xanthelasmas, you can pick up xanthomas, skin
Mm.
issues, they may be present, but mostly we do by clinical markers. And unless you are suspecting some other thing like, endocrine obesity or monogenic obesity, then you go for further parameters. Otherwise, normally the anthropometric parameters, measurement of waist circumference or waist to height ratio is one of the easiest parameters. Waist circumference measurement becomes a challenge in Indian setting. One,
Yes.
because, for especially in women, you can't do away with clothing and make them wear gowns in most of the clinics. While abroad, for every clinical examination, person is made to wear a gown and remove clothes so that clinical examination can be done properly. Here, we don't do it. And, if you are measuring waist circumference over a sari or a thick clothing, then it is of no use.
Right.
But still, you can try if we can measure properly. And the measurements, again, waist circumference has a lot of variables. Now, whether you are measuring on fasting state or fed state, it is going to change. You are measuring, over clothing, without clothing is going to change. You have to measure at the end of, expiration or inspiration,
Yes. Yes.
that is going to change. Then level you are using, whether you are using there are two different methods. You can use highest point of iliac crest or midway between the rib cage and the iliac crest.
Right.
Now, these two can be, again different. So you have to standardize your process, whatever you are doing.
So when we talk about interdisciplinary management, sir, if you could just highlight, I mean, we have read, there are anti-diabetic medications being utilized for, anti-obesity drives and all that, with their pros and cons both. Suppose we have an obese patient, say for example, in our clinical dental practices, what would be the okay, it's referred to the physician, suppose it reaches you. So, or do we have something at our end to guide them across in terms of weight reduction?
So
Or
most important thing to guide them is that first thing they should understand that they have another disease.
Yes,
Right.
sir. Okay.
Right.
You know, problem is a person walks into clinic, it is not dental is very far-fetched thing as of now, I would say.
Right.
A person walks into a physician clinic for blood pressure, gets blood pressure treated, and obesity is not even mentioned on prescription
Absolutely.
in diagnosis. Or person is not even asked for, to undergo for weight or height measurement. Person comes for, diabetes management, gets diabetes managed and walks out.
Right.
Person goes to a general physician, gets treatment for, upper respiratory infection or pain abdomen or whatever. Obesity diagnosis is never made.
Right.
As if it does not exist,
It's regularly available and sit conveniently overlooked, I would say like
So,
that. Yeah.
so, we don't even do a regular height weight measurement in clinics. What else we are looking at? So I think the minimum that we should look at is that everybody walking into any healthcare facility for any reason
Right.
should get at least evaluated for height, weight, waist circumference, and a diagnosis of obesity should be put on paper. And person
Right,
should
sir.
be told that, see, your weight is also more than normal. It is abnormal state. You don't have to stigmatize. Stigmatization is a big challenge in obesity, that you are lazy, you are,
Right.
eating more, you don't care, you are careless, and all that stuff happens. But stigmatization has to be done away. That is most important. And you should, you know, in very positive manner tell person, look, this is not just one condition that you have. In addition to your blood pressure or in addition to your chest infection, you have significant obesity, which is a disease. And possibly if you don't have obesity, your chances of getting these infections is going to go. Your chances of getting dental issues will also be lower. Your chances of getting other health issues will also be lower.
Right. So there are now measures where patients are opting for fast method of reducing the fat, like bariatric surgeries and all that. So do do we have evidence that such fast measures will drastically reduce the inflammation, or do you suggest such
So,
methods?
the first thing is they are not the fast measures. Second thing is obesity is not just weight reduction. That is one thing one has to be clear. So, obesity, once we are treating obesity, what we are trying to do is to reduce the sick adipose tissue in body. And we are able, once we are able to reduce the overall fat burden in the body, why we are getting inflammation? Because we have excess fat in the adipose tissue. Once we bring it down below a threshold level, the inflammation will settle down. All the health parameters will improve. Your dyslipidemia, blood pressure, sugar, everything will improve. Why do we get remission of diabetes?
Right.
So we are not just improving weight, we are improving the whole adiposopathy or the sick adipose tissue. Now, like a chronic disease, as I mentioned, I showed very clearly in my definition also that it's a chronic relapsing treatable disease.
True.
So it
Right.
is to be treated like any chronic disease like blood pressure or diabetes. In blood pressure, what is the treatment? You advise the patient to go for lifestyle modifications, cut down fat intake, cut down salt intake, take blood pressure medication. Now you control the blood pressure. Can you stop the medication? Once you stop, the BP will go up.
True.
Okay. In person with diabetes, you tell them to go for a regular exercise, regular walk, modified diet intake. So all lifestyle intervention and medicine, and you bring down the glucose level. Can you take them to zero? No.
No.
So you bring them down to the normal level. And now next step is to sustain everything to stay there.
Right.
Can you stop lifestyle interventions?
No.
You can't.
Can you stop medication? And you have to keep modifying the therapy as the disease progresses. It is not that you have stopped there, so you will not increase the medication if the glucose goes up. So same is obesity. You have to start with lifestyle interventions, you have to start with treatment, and you have to bring down the weight, preferably to a stage where you get the metabolic benefits. Ideally, if you can, you have to come down to the normal body mass index. Now, that may be a big challenge because some of the people have body
Already
mass
have.
index going more than 2 times also.
Mm.
So we know that there you will get help benefits by coming to 15% lower or 10% lower. But in now the recent discussion is why we don't target the normal body weight. There is treatment goal is also very clear. In diabetes, you want the fasting glucose between 80 to 120 and postprandial between less than 160. In blood pressure, you know that you want blood pressure to be 140 by 90 every person. How much weight you want for every person? So target is a challenge. So the first target is to bring down the weight by 15%, 10 to 15%. And you will achieve health benefits. And once you achieve that, most important challenge is to stay there, sustain the weight over long-term period. Now, to sustain that, you have to continue therapy. So bariatric surgery will bring it down to a certain level, but after that, you have to continue to sustain it. And you may need to continue medication, lifestyle changes, diet, everything to sustain it there. Similarly, for weight management with medical therapy, all these injections are not shortcut thing. They need to be
Right.
continued for lifelong. It is not that they will reduce weight to, they will bring it down to zero. Weight will come down, it will stay at a lower level. And then
Right,
you
sir.
have to maintain therapy on long-term basis.
I think it's more of a cosmetic appeal has come probably with, as a practice, I would say that these procedures are
I
doing
think
great.
people
Huh?
approach more with cosmetic appeal, but there are multiple issues with obesity which
Exactly.
people are recognizing now, and people come for health reasons also.
Right. Because I have two of my, colleagues, they had undergone such surgeries. And believe me, sir, they just rebounds back from where they started. So it was a
So,
futile effort,
so
actually.
I have lots of patients who had undergone bariatric surgery, regained all the weight that they had lost, in fact, regained more, and now we are treating them for again weight loss. So bariatric surgery is not a quick fix.
Even liposuction for that matter.
Liposuction has nothing to do with obesity. Liposuction is only a cosmetic procedure.
Huh?
It is not nothing to do with obesity. It has no health benefit.
Okay, right.
In fact,
Great.
subcutaneous fat is good fat. It is not bad fat.
Yes.
It is the visceral fat which is more important. But once you have excess subcutaneous fat, the deeper tissues again, you get inflammation. That's a separate story. But taking out visceral fat, subcutaneous fat, it is of no use. First, it is just going to give you cosmetic benefit. Second, it is going to come back.
Right.
So just one last question, like as you rightly said that when we tell a person that you are fat, you are fat or you're obese, it also probably is stigmatizing that person, or there is body shaming. So these things also
So
come
we
in.
we don't say that you are fat. We always discuss. First thing is normally, the guideline is now you should ask the patient that would you like to discuss about your weight?
Right,
You know,
right. Huh.
make the patient comfortable that if you are interested, then we can discuss that. But I have a little disagreement on this because you can do it by asking directly also without stigmatizing. So rather than asking him, would you like to discuss about your weight? I would rather tell the person, look, you have diabetes, but your major issue is not diabetes. Your major issue is
Right.
your weight. And if you
Yeah,
control your weight or if we put you in weight reduction, your diabetes may get into remission also, or
that's
you will
easy.
be able to control it much better.
Right.
Second thing, we are just controlling diabetes. If you are not controlling weight, we are
Yes.
not going to cut down your cardiovascular risk anyway.
Right.
So we have to tackle your weight as part of the problem,
Right.
or maybe, root cause of the problem. So it's how you discuss and how you convey to patient.
True. Right.
I think, sir, that is a wonderful discussion today because
Mm.
this is one aspect we were missing,
Mm.
and it is the basis of not only diabetes but multimodal disease. Not I was talking about comorbidity, but there are
So
so many other diseases.
obesity is possibly mother of all
All
important diseases
Right,
true,
of adult life.
true, true,
right,
true.
right.
We just talk of
Mm.
obesity as, diabetes or blood pressure or
Mm.
dyslipidemia or heart disease. There it is leading to massive liver cancers. There are 12 cancers which it increases risk of
Mm.
obstructive sleep apnea,
Mm.
then osteoarthritis, then GERD reflux,
Mm.
GERD, then
Mm.
mental health challenges, so much of depression, so much of
Right, right.
psychological issues, psychosocial incompatibilities, the cost of therapy, the
Mm.
social isolation.
Mm.
There are so many things that we don't discuss routinely. The list currently is touching 240 diseases which obesity is
Oh.
predisposing to.
Oh, okay. And where does India stand as far as current consensus, which are available, sir, in terms of you know Western countries comparisons? Where do we stand? Diabetic capital it is. How about the obesity front, sir?
Obesity, we don't have comparison because there are countries which have much higher percentage. But if you look at the
Mm.
numbers are very, very high in India, and
Mm.
possibly we may be one of the biggest countries, one of the countries with
Contributing,
biggest numbers.
contributing to obesity rise. Yeah,
Yes.
true,
Also,
true,
probably,
true.
sir, because as you rightly said, we have not properly understood what is obesity, and we have
Mm.
missed it by not measuring the anthropometric matters and not writing on the prescription paper, like
Mm.
you said. It should be
Mm.
mentioned that this is the weight, heights, WHR, waist, and that would probably start the process of
Yes.
awareness.
Thinking, yeah,
Yes,
yeah.
Yes.
The first consultation, basically, the way they goes, as a SOPs. So
Yes.
might not be getting a comment. That's wonderful. Dr. Anurag, do we have any chat box
no,
queries? Do we have?
no, ma'am, no,
Not there, no?
no, yeah, ma'am.
So, Dr. Makkar sir, this was a very exhaustive, illustrative learning from us. I mean, I think we have learned like a teacher teaching us. This is like excellent interaction with you, sir.
Thank you, ma'am.
And
I think I learned a lot about oral health.
no, it
I
was lovely,
you
sir.
know
It was very nice.
I don't know whether I could do justice with the oral
You
health part.
have actually given
Absolutely, sir.
a broader perspective, and unfortunately, we could not have Dr. Punya, but you have a broader perspective of your content, sir. It was wonderful, sir. Great.
Thank you.
And I
Thank you.
think you are overseas, so kindly do enjoy. You are overseas
No,
somewhere,
no,
you
I am
said, no?
back. I came
You're
back
back?
last night.
Okay, great, great, great. So thank you so much, sir, for having a part of this webinar, and we'll catch up soon again.
Thank
So
you so
will
much.
that
And thank you
be
so much for the opportunity.
absolutely, sir,
The
and we'll
pleasure is
connect
ours,
again,
sir.
sir.
Thank you, sir.
We'll connect
Thank
again,
you.
sir. So we'll just wrap up the session, and till we meet again, so we'll just sign off. Okay. Thank you so much, sir. Good night, sir.
Thank